We are going to be talking about ICTAL, interictal continuum. So one of the questions that I'll start with is why talk about ICTAL, interictal continuum? I think one of the reasons is EEG data in the critically ill patients, so complicated, and this ictal interictal continuum is something that we see quite a bit. It's something that the EG techs are often calling the epileptologist about. These patterns show a lot of epileptiform activity. These patients are at high risk to have seizures. And I think if there's a good understanding about what we're describing, so we can be able to say, is it ictal? Is it interictal? And to be able to communicate that between the critical staff members, so between the EG techs, the epileptologists, the intensivists, everyone knows what we're seeing, and I think that will really help with communication and hopefully improve patient care. So critical care EEG discussion is definitely timely here. There is the 2021 ACNS guidelines on critical care terminology. And so I think this is really a very, very valuable resource. And I think a lot of people watching this have already have this as a resource and are using it. But it's something that I think we can really get a lot out of, because there's a lot of meat in this guideline. And one piece of that we're going to go over today is the ictal interictal continuum piece. So here's a slide. This slide shows the ictal interictal continuum. And so here's an EEG, very abnormal, ugly EEG, all these epileptiform discharges. And you as the EEG tech may be saying, is this seizure activity or is this not? And so what the continuum is it doesn't meet the strict criteria for electrographic seizure, but there are concerns that the spikes are frequent enough where they could be having an effect on the patient. And so that's what the ictal interictal continuum is, that even though it doesn't meet all the criteria for seizure activity, the epileptiform activity could be having an effect on the patient that could have the same ramifications. So some terminology, this I think everyone kind of knows this, but ictal obviously is seizure, interictal is between seizure. And so that's what the continuum is looking at. So let's talk about definite seizure activity. And so the EEG of a definite seizure, if it's greater than 2.5 hertz, greater than 10 seconds in duration, then it would meet criteria for electrographic seizure. So if you look at these spikes, so here's a sharp wave, here's a sharp wave. And so this is, they're kind of going along at about 1 to 2 hertz. And then here, these sharp waves are now getting up to 4 or 5 hertz. And so now you're getting into the territory of definite electrographic seizure activity. Now we'll kind of go over the next few slides will be interictal, ictal, and then kind of getting into the more of the continuum. So let's start with the interictal. So this, I think most of us would probably call not on the continuum and not seizure activity, more of an interictal pattern. Here the discharges, you're seeing them at about 1 hertz, and they're nice and clean, sharp waves. So these are generalized periodic discharges, and they're going along at about 1 hertz. So I think you could be comfortable calling the physician saying, hey, we're seeing these epileptiform discharges, but I think you would be confident that this is more in the interictal category. Now here's the electrographic seizure. And so here you're seeing the sharp waves kind of building up, and then see how it's getting more and more kind of spiky. And also it's evolving, it's changing, it's evolving in several different ways. The morphology is changing, and also the frequency is becoming more frequent, and so that's another way it's evolving. Also, the distribution is evolving, where it's becoming more widespread. So here's even more widespread, involving beyond these more temporal, getting into more of the kind of central chain. So again, more of a clear-cut electrographic seizure. And here we're approaching this. This actually would probably not technically be qualifying as ictal interictal continuum. So this is actually more probably just interictal. And so, but it's certainly abnormal, certainly gets your attention. You'd be certainly contacting the epileptologist, letting them know about this. But it probably does not meet the criteria for the ictal interictal continuum, because they tend to be more 1 hertz. And so once it gets a little bit more active here, now it's getting to be a little bit more commonly 2 hertz, kind of what. So it's more 1 to 1.5 hertz, and I think that's getting to be more in that continuum. So literally, you're just kind of counting how many of these sharp waves. So here's from here to here is 1 second. So now you're kind of getting into that. Kind of looks like 1 there. Now there's 2 here. So it's kind of averaging out to being about between 1 and 1.5. So again, not getting to that 2.5 threshold for the electrographic seizure, but certainly a concerning record. Now this is getting even more active and probably a little bit more debatable. Is this ictal, or is it on the continuum? This slide indicates that it's technically on the continuum because it's more of a 1.5 to 2 hertz. It is concerning, though, with how rhythmic it is. And I think this would be an EEG pattern that we would be pretty aggressive about treating. Now, here's another subset. So we've been talking about the interictal continuum, and just to kind of review it, here we are, that's interictal. And here's, no doubt about it, there's seizure activity. Now here we're getting into the continuum. And the continuum is mainly just because of how frequent the discharges are. Now these discharges themselves are too slow to be in the continuum, more like 1 hertz or 1.25, but they really are more in that plus modifier. So you have the plus modifier. See how they have these spikes? So you have the sharp waves, and then you'll see these little spikes. And so that makes you much more along the lines of, this is kind of on the ictal interictal continuum. And so see how they kind of have those. So here's kind of a pretty clean one, but here's one where you have little kind of fast activity, a little bit of sharp activity, and how kind of some rhythmic activity intermixed. And so these are described as sharp GPEDs with superimposed low amplitude quasi-rhythmic fast activity. And so that's where you get into that plus modifier. Here's another plus modifier. So again, this is where you might be calling something more on the continuum because of those plus modifiers. So in summary, the kind of the way things go is you have the interictal patterns. And so see how slow these are. This is like 0.5 to 1 hertz. This is all interictal. Then you go to the ictal interictal continuum, which is 1 to less than 2.5 hertz. And then finally, you have the more clear-cut electrographic seizure activity. So that's kind of my summary piece on that. So the ictal interictal continuum, the significance, when the EEG is active enough to meet criteria for the ictal interictal continuum, we usually treat with anti-seizure drugs and taking a relatively aggressive approach. And the reason is the patient is almost always encephalopathic and comatose. And so if the EEG is active enough to meet the criteria for the continuum, then you're going to want to try to quiet the EEG down. Again, that's where EEG tech staffs are just incredibly valuable part of the team. And let's see, so my conclusions, ictal interictal continuum is an EG pattern that we commonly see in critically ill patients. A clear understanding of what is more interictal, what is more ictal, and what is on the continuum can be helpful. I think it actually kind of calms the EG tech and certainly the epileptologist if we have a good feeling as to which category the patient is in, and that helps guide our treatment. So hopefully this information will continue to improve communication and optimize patient care. And so I'll just say thank you, and we're just starting these lectures, and so if there's any ways we can improve them, please let us know.